Okay.
For your session, I always seen many doctors they do join.
Okay.
Even
Hope
today's
it's
topic is
beneficial.
interesting.
Hmm.
Sir, you keep it every month
Just
actually.
as a,
It will be a good.
it's a rare specialty, but it's a multi-system disease.
Right, right.
So people need to know more about it.
Hello.
So I remember when I was a medical student, we had one rheumatologist coming to south for the whole weekend. He stops at
Okay.
Trichy, Madurai, Tinavali, Nagarkoil. So weekend gone and then goes back to Chennai. So, but now we have rheumatologists every city.
Sorry,
Right, right,
sorry, sir,
right.
to disturb you. So we are live, Vishal, sir. You can start, sir.
Okay.
Yeah. Thank you, sir. So I welcome you all. I am Vishal. On behalf of Zydus Synovia, I welcome you all for today's interesting webinar and on this platform, which is Ruma DG Conclave. So today's topic is very interesting, and I'm sure that everybody will be get enlightened with this wonderful topic. The name approach to inflammatory back pain in the young. And today's session will be taken up by our respected Dr. N. Subramanian. Welcome, sir. Thank you very much for taking out your precious time today for all of us and taking up this very interesting topic, which is approach to inflammatory back pain in the young. As far as introduction is concerned for Dr. N. Subramanian, he is MBBS MD MRCP UK, MRCP CCT Rheumatology, and FRCP Edinburgh, FRCP from Edinburgh. Sir is a senior consultant rheumatologist and he is currently practicing at Shifa and Aruna hospitals, Tirunelveli. And I again thank you everyone in the participants and in the audience that thank you very much that you have also taken out your weekend time to watch this session today by Dr. N. Subramanian. So if you have any query, any question, you can put it your question in the chat box which is there in front of you all, and that questions will come to me, and at the end of the session we'll take up one by one all your questions. So over to you, Dr. N. Subramanian. Thank you very much, sir.
Hello, good evening to everyone. So first of all, I would like to thank the Zydus team for arranging this CME or virtual CME. I hope the next half an hour we can focus on the back pain for younger patients. I hope my
Yes,
slides
sir.
are visible, Vishal?
Yes,
Yeah.
sir.
Okay.
Slides are visible.
Okay.
Your voice is very clear. Thank you,
Right.
sir.
Thank you. So I work in Tirunelveli and also in Velamal Medical College, Madurai. So I trained in Tirunelveli and then subsequently did my MD in Keel Park, been to abroad, and currently as a rheumatologist and physician, and a few awards to my names and also publications. I'm very much interested in raising awareness among the public about the rheumatological diseases. So back pain, we all will get at some point in life. Back pain in the younger population is increasing, partly because of the mechanical factors. Racing bikes nowadays, roads are very bumpy, jumpy. So we all will get some point back pain even in older patients. So I'll share with you a few causes about it. But the main focus would be on inflammatory back pain. So we can discuss in detail about inflammatory back pain and how they manifest, and also a few case-based examples to make you understand about how we manage or how we evaluate patients with inflammatory back pain. So low back pain, it means people think it's a youth leaving our body. Compared to the animals, we have erector spinae, and the spine will be upright. So the back pain it can be a hazard. So this is an X-ray which has established inflammatory disease of the spine with a fused spine, so it's a rigid spine. So 80% of people will have back pain at one point in time. So that is the maximum, fifth reason to visit any doctor. So normally we all will get back pain due to mechanical factors like lifting, twisting, physical conditioning, or trauma to the back, sports, cycling, swimming, bike riding, and so forth. So obesity is also a conditioned risk for developing back pain. So if we look at differential diagnosis, what are the possible reasons for the back pain? So it's predominantly musculoskeletal strain in the younger population. When I say young, it could be starting from the late teenage up to 30s and 40s. Some people may have a disc problem causing sciatica and also canal narrowing, spinal stenosis, or it could be due to fracture. That can be due to many reasons, usually a bit older age group. So neoplasm is also older age group. Infections of the spine, ankylosing spondylitis, and choroid syndrome. Some people have fibromyalgia syndrome with psychogenic problems. So the red ones are more common in the younger population. So we are just going to cover that in a bit. So what are the main reasons for back pain in the young, which are more mechanical? Is frequent bending and twisting, lifting, whether it's a sitting job, or whether it's a manual job, whether it's a laborer, whether it's a farmer. So we all will get, but it's a farmers will have more physical activity. So the muscles are more strengthened in that sense. So sedentary life is more prone to weak back. So that may cause herniation of the disc because the muscles of the back are weak. So that's a strain on the spine. Trauma is little trauma, or it can be due to bike and high sports activities. Just share with you a few X-rays. This first X-ray shows, and this is like you all know, vertebra and intervertebral disc space, and this is the canal, spinal canal. So this narrowed intervertebral space that is due to spondylolisthesis. So this vertebra has come in forward to the other vertebra, so that's why it is spondylolisthesis. This is you can see the osteophytes in the level between L4 and L5 narrowed space. And this image shows the MRI. These are X-rays, the MRI showing a herniated disc compressing the spinal canal. So that also can give you back pain. So these are all teaching slides. It's more common in the later age group, but nowadays because of obesity, so it's coming earlier in the age group too. So this is a bit more diagrammatic representation of the L4, L5 disc herniation, and you can see the multiple levels of stenosis of the spinal canal. And this is more exit foramen in the L5S1 level. So that's again entrapment neuropathy, which will cause back pain and the sciatica pain. Okay. So that's more mechanical. Mechanical pain means usually most with the activity, gets better with the rest, and usually disc-related symptoms will settle over a few weeks, 4 to 6 weeks, and physiotherapy and strengthening exercises would do good for that. So this is a patient who was 22 years, 2 months history of back pain, now physically unable to walk. So you can see the total vertebra is collapsed, and you can see the infection or abscess tracking down into the spinal canal. So this is more infective. So it eats away the body of the vertebra. So that is more common with the tuberculosis of the spine. So anybody who has neurological complications, it's more emergency. So you need to have MRI first, quickly, and get on to the diagnosis and treatment appropriately. So this is TB spine. This is a 26-year-old female who had delivered a baby 6 months ago, noticed right hip pain and back pain with fever, but there is no history of cough. Because it's more unusual with the fever and hip pain, so I've done MRI, which you can see so effusion in the right hip compared to the left hip, which is quite normal, and the sacroiliac joint is quite okay. So this suggests unilateral synovitis of the hip. Any unilateral disease, single joint, which is monoarthritis, we call, is equal to infection unless otherwise proved. So it's called septic arthritis. She's currently on anti-tuberculous therapy. So it's not staph. Okay. So infections, TB, spine, osteomyelitis, previous disc surgery can also predispose to infections. And usually vertebral percussion gives more tenderness. So that's the important point to note. And the fever can be absent in half of the patients. Okay. So disc is one problem for the young people. Infections is another one. This is the third patient. So 26-year-old male, recently married, but this is a story 5 years ago. Okay. So he was admitted with the hip and back pain. So CRP was high. So normally, what do we think? So because of webinar, it's difficult to have interaction, I think. But the differential diagnosis, we normally think, okay, it's more infective, or it could be reactive to an infection. So if in Western countries, people think about chlamydia and gonococcal infections, here it's usually urinary infections. So it could be reaction to an infection. So that is one possible differential diagnosis. So the hip pain, so usually inflammatory back pain gets better with activity. So back pain and hip pain, better with activity, worse at night, nocturnal pain, stiffness in the morning, and also buttocks pain. So these are all characteristics of inflammatory back pain. He had hip problems also, so he didn't have specific history, but he had diffuse pain. So, and it was worse at night. So that is a factor also. So reactive arthritis was the first differential. Subsequently, we thought it could be sexually transmitted diseases, or simple infection. Septic arthritis could be a possibility, or it could be ankylosing spondylitis, which is a inflammatory spinal rheumatic disease. So these were the differentials. So he went on to have infective screen, cultures all have been done. CRP was high, so he was given antibiotics. Cultures came back negative, and then he had an MRI. So this MRI showed, you can see diffuse bone marrow edema in both sides of the sacroiliac joint on the right side. This is the left side. He had actually erosions on the left side. Oh, sorry. So he had active lesions in the right side. He also had effusion in the right hip too. So this is bilateral sacroiliitis. So bilateral disease is more inflammatory, less likely infective. So he went on to have HLA-B27 also, that was abnormal, and he is currently on biological treatment. He is living in Muscat nowadays. So he was 24 at the time, now he is 29. So this is ankylosing spondylitis, which is an inflammatory disease of the spine, which doesn't affect only the spine, but it can affect any system. So it's a spectrum of disease of rheumatological manifestations. So a few weeks ago, we discussed about the rheumatoid arthritis, which is a small joint peripheral disease, whereas ankylosing spondylitis is a spinal predominant disease, but it can also affect the peripheral joints. So this is patient number 4, 17-year-old chap. So he had a back pain, so very stiff for the last 3 weeks. So because we are trained rheumatologists, we quickly get on to think about ankylosing spondylitis, and MRI will be done. But usually the early morning stiffness, and for 3 weeks does suggest more of inflammatory etiology. So you can see, so the MRI shows this is a trochanteric bursitis of both sides, very well classically described and shown in the MRI. So this is trochanteric bursitis, which is again a feature of ankylosing spondylitis, and this shows, you can see the right sacroiliac joint bone marrow edema, and also in the left sacroiliac joint. So this boy has definite ankylosing spondylitis. So why I'm sharing all these is to get you aware that MRI is quite essential for diagnosing ankylosing spondylitis nowadays. Usually, when I was a medical student, we used to have a SI joint, a sacroiliac joint X-ray with the pelvis X-ray, but it gives only changes after developing erosions, which we have missed the boat for treatment. How to suspect? So anybody who is young, I've got a youngest chap who is studying 9th standard. So back pain in a young, usually unusual, unless we have ankylosing spondylitis, full stop. Think about infection, as I discussed before. Think about unusual infections too, but this is have to be thought in mind early on. So back pain for a few weeks or days, worse in the night, buttocks pain, and also referral to the thighs, and also trochanteric bursa, which is on the lateral side of the thigh. It can have Achilles tendonitis and heel pain too, which is like soft tissue symptoms, and worse in the morning and stiffness in the night. So very good response to steroids. Anti-inflammatories, which is non-steroidal anti-inflammatories. We always get a history of systemic disease. So my history is always from head to foot. So every organ we think about linking symptoms so that we get into the spectrum of ankylosing spondylitis. Definitely we look at HLA-B27, which is the genetic marker, biomarker for patients with ankylosing spondylitis, but not all of them will have positivity, and the MRI imaging of sacroiliac joint and also spine if required. So it's a primarily disease of axial skeleton, but peripheral joint involvement can also be up to 70%. So all rheumatological diseases are women dominant, but this is one condition which is more men dominant. So and 95% of people with ankylosing spondylitis share the genetic marker HLA-B27. It's the the end result is it's Robolike spine. So rugged Jesse spine or fixed spine, rocker bottom spine, something like that. It's all a rigid spine, if it is not treated well. So it could be the spine, but it can also be manifesting with peripheral joint disease, eye disease, and also skin disease and bowel disease. Skin is more psoriasis associated, and the bowel disease is more ulcerative colitis or Crohn's disease. So MRI has been helpful in the last 2 decades. So until MRI is developed, so people have studied the initial onset of symptoms and getting to the diagnosis. It has been nearly a decade, up to 9 years. Sometimes it takes for the patients to get to the diagnosis. But now with the MRI, we diagnose pretty much within the 4 weeks. So, so positive MRI of the sacroiliac joint, inflammatory lesions, bone marrow edema, osteitis, and other features supportive of sacroiliitis. Okay. So the factors involved are genetic factors, HLA-B27 predominantly, but IL-23 are also environmental factors, including bacteria. So diarrhea and urinary infections can predispose to development of sacroiliitis, and skin disease like psoriasis, eye disease, uveitis, sacroiliitis, peripheral arthritis, enthesitis, and colitis. So all can be associated with the ankylosing spondylitis. It is a spectrum of disease called spondyloarthropathy or arthritis. So this is all manifestations of psoriasis. So psoriasis of the skin, psoriasis of the nails, so in the hair, and the dactylitis of the fourth toe, and the deformities, and also in the nail changes. And Achilles tendonitis here, this is pitting of the nails. So this is psoriasis. Psoriasis itself can be manifested with ankylosing spondylitis. It all forms part of seronegative arthritis. Seronegative means rheumatoid factor negative. So although rheumatoid factor is only about 54% specific, it's highly non-specific. So these patients will have rheumatoid factor negativity. Okay, so few words about uveitis, which is another accompaniment of ankylosing spondylitis. Usually, it's a non-granulomatous recurrent uveitis. So 50% will have B27 positivity. And 40% of patients who had ankylosing spondylitis will have uveitis at some point in life. So iridocyclitis cyclitis is less common, and if it is psoriasis related, they can have conjunctivitis and scleral disease too. So this is spectrum of spondyloarthritis. So you can see acute anterior uveitis with pus, which is hypopaean. This is unilateral uveitis with B27 positivity, and this is KPs in the granulomatous pattern. So keratic precipitates in the uveitis. So that's about the IE and ankylosing spondylitis. Now we coming to the HLA-B27 with the gut. So a lot of innovations have developed in this angle. So this could be the primary trigger. So patients will have HLA-B27 as a primary programmed in their gene, okay, since birth. But some factor triggers them to develop autoimmune disease, and that has been predominantly from the gut microbiome. So any infections from diarrhea or gut alteration that predispose to development of ankylosing spondylitis, and that has been very much proved time and again, both in the animal studies and also in the human studies. So HLA-B27 connection with altered flora causing diarrhea, colitis, and Crohn's disease. So those two are inflammatory bowel diseases which are closely connected with ankylosing spondylitis. Even last week we had a patient who has diabetes, hypertension, obesity, is already 64. He developed diarrhea, and now he has both colitis and also ankylosing spondylitis with the peripheral arthritis, which was resistant initially to most of the treatments, but now it's under control. So the patients have inflammatory back pain. Think about ankylosing spondylitis, and the screen for other systems like eye, skin, bowels. Unusually, we can give apical lung fibrosis and also aortic valve disease, but it's only for specialists, so you don't have to worry about it. So normally when the patients are suspected, we think about inflammatory markers, which include CRP and ESR. And we always routinely do sugar and thyroid functions because they are all autoimmune disease, autoimmune linked. And HLA-B27 by PCR is required predominantly to pin down the diagnosis that it is ankylosing spondylitis, nothing else. Okay, and again, people will ask because it's a younger population, so they have the question about whether it moves to children, whether the children will be affected, and so forth. All these questions. HLA-B27, it's present in 8% of Western population, and in India it's about 3 to 6%. So it's just average. But not having HLA-B27 doesn't make you have the disease. You know, so of those 5%, so only 10% of those 5 only will develop. All those patients who have HLA-B27, only 10% will have disease with inflammatory spinal disease. So not to worry that even if you have B27, but you are slightly programmed or tuned to develop into inflammatory disease. So you may have to be a bit careful about risk factors, which includes obesity, smoking, diabetes, unhealthy practices, alcohol intake, and gingival, oral health. So all those things. So there are specific criteria about how we get to the diagnosis internationally, classifications in UK, US, Europe, and we follow one of these really. So usually patients will have arthritis, and if they have sacroiliitis in imaging, B27, uveitis, infection history, bowel disease, psoriasis, one among these is enough. Or if you need two, if you don't have a MRI abnormality or you can't do MRI, then you can be classified with these findings, which includes peripheral arthritis, dactylitis, bowel disease, and a positive family history. So that could be also taken into account. So to come to a diagnosis, definitely for ankylosing spondylitis. Now we are pretty much definite and convinced in these because it's a chronic disease. So we are giving a name to that disease, and patients are going to carry on for a longer period. So we need to be 100% sure that we are in the right approach and right track. Okay. So this has been published last year by our team. I have released a supplement on spondyloarthritis in Indian Journal of Rheumatology as an assistant editor. So this is Indianized way of flowchart for diagnosing spondyloarthritis. So you need to have low back pain with age less than 45, early morning stiffness in the spine, predominantly of more than half an hour, better with activity, buttock pain, and response to anti-inflammatories. And ESR, CRP, HLA-B27. If we do have only X-rays, that could be suggestive, but then after referring to a rheumatologist, we do MRI of sacroiliac joint and also the whole spine. So sometimes MRI SIJ will not have early feature, so it may have costochondritis, may have membranosternal disease. I had 3 patients who have membranosternal disease. So it could be chest wall pain, it could be back pain, it could be neck pain. So it could be bursitis and also tendinitis. So all these things are part of in evaluation. Okay. So if the MRI is normal and B27 is normal, then peripheral arthritis only, then think of other diagnosis, provided the CRP is also normal. Okay. So this is our colleagues from UK who also returned in that supplement. So axial spondyloarthritis, which is spinal disease, peripheral spondyloarthritis, psoriatic arthritis, IBD related arthritis, and reactive arthritis. All these form part of the same spectrum. Okay. So which disease will have which manifestation? So that is the table which gives you that. So ankylosing spondylitis, we do have more spinal disease, and if it is a peripheral disease, it's predominantly hip, knee, and ankle, and 25% of patients. So uveitis is more common with angst-spond, whereas dactylitis is less common. Dactylitis is more common with psoriatic arthritis, which is the single digit which will be inflamed. And if it is reactive arthritis, it's more peripheral arthritis, which is knee and ankle. And again, dactylitis is more common with the reactive arthritis. If it is enteropathic, then it's knee and ankle. So you can see pretty much knee and ankle are involved in every type. So these are all manifestations. And uveitis is also common with all of them except enteropathic, because that's more with the bowel disease. Okay. So any patient with arthritis, it's a team effort. So we need general doctors and specialists, rheumatologists predominantly, and sometimes we do need orthopedic surgeon. So if you have septic arthritis, we need treatment. If you have very significant damage, you may need a joint replacement in the peripheries. Spinal, usually we don't need surgery. In fact, I have 2-3 patients who had a rigid spine, So already fixed, established disease, but they had a fall and a fracture. And now he has some movement in the spine. So he is the one who doesn't want any treatment for the fracture. Although it's already he's got rigid spine, so there is little crack which doesn't give him more pain, whereas it is more mobile. So, so that's the story. So we need physiotherapy, definitely, because spine needs active movement, and drugs form only part of the therapeutic strategies. So common treatments, so predominantly not anti-inflammatories in the early stage, exercise from day one. Steroids are only less commonly used, and biologics and DMARDs are predominantly used. Okay, it's a long-term disease, male in a working population, so they will need to have regular checkups. So now we look at management. So there is a disease activity criteria called BAS-DI and BAS-P, which you don't have to worry about. So we, based on that, we monitor the clinical activity and also function status and get on to the treatment. So it's a axial disease, a peripheral disease. So we separate that. Patient education is important. Exercise is very important. Anti-inflammatories. And if it is a single joint peripherally, we can inject. And then sulfasalazine has been time tested to use in ankylosing spondylitis, and anti-TNF treatment is being used liberally nowadays with the advent of biosimilars. So again, this is a European recommendation, which is predominantly the same. So patients, if it is untreated, this is what happens. So anti-inflammatories definitely inhibit the structural progression. So in addition to the symptom control, functional improvement, and also radiological progression. What I mean is, so it reduces the damage to the joints and the bones. So that is definitely there. And in addition to the biologic treatment, it has been very much useful. Okay. So this is a standard slide for disease-modifying drugs, but we don't use all of them. Sulfasalazine and leflunomide are predominantly used for ankylosing spondylitis, and these are all not used. And the biologics, it's pretty much many of them are used except rituximab and the tocilizumab. All of them are being used or have been licensed to use for ankylosing spondylitis and other complications. In India, biosimilars are increasingly being used, and we have also been using both drugs. So steroids can be given for a short period, for 2-3 weeks, and methotrexate can be given for peripheral arthritis. Leflunomide is given for peripheral and spinal disease, and sulfasalazine works for both bowel and spinal disease. Hydroxychloroquine we do not use for ankylosing spondylitis. So because it can bring on psoriasis if they have already a propensity to develop psoriasis. So little information about biologics. Everybody needs to be aware, especially with the advent of COVID and also varied infections. Nowadays, people are pretty cautious about newer drugs. But biologics have been in use since 2002. The first drug was infliximab. So it has been licensed in very many conditions, more in rheumatology and oncology, but in every specialty they do have biologics. They are protein molecules prepared from recombinant DNA technology, and it is a lesser side effect profile compared to the traditional immune modification drugs. You can see there it's all MAB, monoclonal antibody. So it will be in their name. So again, this is, I don't think you need to be worried about. This is all cytokine blockers. Tocilizumab is being used for COVID, which you are all aware, which blocks the interleukin-6. So it's up there, and different cytokines will be blocked by these agents. So thereby reducing the disease activity, progression, and also disease cure-like approach if we go on to treat early on. Okay, so these are all drugs for ankylosing spondylitis. You can see etanercept, infliximab, adalimumab, golimumab, cetrolizumab, secukinumab. They're all approved since nearly more than 10 years now. So, and it's all being used in India too. Biosimilars are specific agents similar to biologics, manufactured in cell lines. So they have some modification like glycosylation. They are cheaper versions. So nearly cost will be 50% of biologics. That again being used more in ankylosing spondylitis. So I continue to share our experience across different countries. So Velamol students continue to study these patients and present in different fora. So this was a short review of biosimilars published in Germany Autoimmune Congress in 2016. So at that time we had about 5 patients of spondyloarthritis on biosimilar drugs. So you can see all the drugs and the different diagnoses. And this is not being published, it's a work in progress. So it's a 2-year observational data prospective study of patients with inflammatory back pain and treatment response in 2 different centers. So these are BASDAI and BASP score, which is the disease activity score showing improvement from pre-treatment, So pre-treatment up to 2 years. This is 2 years activity. It has reached BASDAI of 2, so which is nearly in remission. Okay. Both functional and also BASPI is a functional activity index, whereas BASDAI is a disease activity index. So physiotherapy has a main role. So every rheumatology unit should have a regular physiotherapist, and the spinal focused physio would be important. Lots of techniques, yoga, Tai Chi, and specific techniques can be used for spinal mobilization and peripheral. In fact, every rheumatic disease we need physiotherapist input. So this is even orthopedic surgeon has agreed that we need a multidisciplinary approach in rheumatology. So, so it's a team concept. So I always tend to involve the patient's family too, because they need to support when the patients struggle at home for the daily activities. So this is a preface to editorial along with Dr. Vinod Chand Ravindran. It's about advances in spondyloarthritis, which is the update which were published through Indian Journal of Rheumatology last year. So I would like to show a few more images to make you aware of complications. These are patients who had long-term steroids. So this one, it's avascular necrosis of hip after 1 year of continuous steroid treatment for arthritis. So quite young, she's not married. So this is an older patient who had both these vertebrae gone due to osteoporotic fracture, secondary to steroids. So steroids we have to somehow minimize for less than 3 months. So every meeting I tend to make a point that we need to reduce the steroids to at least bare minimum possible, please. So this is a patient with psoriasis, which we have seen last week, who had a persistent pain in the little toe. So we did a MRI, which showed both fourth and a little MTP and dactylitis of these two with the you can see tenosynovitis changes, which is again due to spondyloarthropathy. Okay. So this is an MRI showing knee effusion. So anybody who comes with a swollen knee, age group young, exclude injury and a fracture, think about infection. Next thing will be inflammatory arthritis, similar to seronegative group. So rheumatoid juvenile is less likely compared to juvenile spondyloarthritis. So we don't want to see patients like this, fixed spine, where you can see bamboo spine. It's a calcified spinous ligament. So literally the patient have lost the spinal movement. So normally we ask them to bend forward, touch the toes, which is a Schober's test, and also spinal lateral movement, and also posterior movement, and stand in front of the wall with your back, and whether you can touch the wall with your occiput. So there is assessment of the cervical spine movement. Okay. So we're coming to the end of our talk. So for people who know Tamil, so I normally say joints are friends for us. So they take us to every part of the world or every activity. So we need to look after them. Then they are friendly. So the last 7 years I've been in India. So I find that ankylosing spondylitis is more common in child, and it's one end of the spectrum of spondyloarthropathy. So early teenage to college days, it affects the younger population. So their career ambition. There are 2-3 patients who have put in army training. So I had to support them, and now into the army after early treatment. So there are people who are hockey players, but because of financial issues, she couldn't continue. She was in only a sports school, all the year she will be continuing to play, and but her joint disease didn't settle, and they couldn't afford further treatment. So it's sad, but there are other people who are cricket and tennis too. So some patients. Okay. So MRI definitely is a tool for establishing a diagnosis early on, and early intervention is the key to successful disease control. We have seen improvement of the bone marrow changes following biologic therapy. So, which in a way it's kind of cure, but we have to maintain the disease remission. So recommendations, history is important. So back pain, younger population, nocturnal symptoms, buttocks pain, early morning stiffness is equal to ankylosing spondylitis. So do ESRCRP, HLA-B27, an MRI with the STAS sequence would be helpful, and give NSAIDs, which will help them until they get to see the rheumatologist. Sulfasalazine if it is for peripheral arthritis, whereas if it is spinal disease, they may need biologics or biosimilars. So with that, I would like to conclude today's talk. So remember, it's a spectrum of disease, not only spine, not only peripheral joints. Think about skin, eyes, bowel, and also think about lung. So I would like to stress on safe practices during this COVID pandemic. Now it's COVID-20, although we are still using COVID-19 vaccine, which is the only available one. So get yourself vaccinated, use mask, hand sanitizers, social distancing, avoid unnecessary group meeting and travel, and keep you safe, because we do see new strains developing from COVID-19. So I thank organizers and the audience, and open to any questions now. Thank you.
Yeah, thank you very much, sir. Am I audible, sir?
Yes, indeed.
Yeah, indeed, it's our pleasure, sir, to always bring you on this platform, and we really thankful as a Zydus Synovia team that you always given us this opportunity to deliver a wonderful session like today's session also. I'm sure that everybody in the audience have taken advantage and benefit out of it. So let us move on to a few questions which has been asked by the audience quickly, sir. So shall I ask, sir, first question?
Yes, please. Go ahead.
Yeah. The first question is, sir, how would you differentiate a bone or neural compression induced pain from inflammation originated one?
Okay. So if it is compression pain, so it's predominantly, the lower lumbar vertebra, more commonly in younger population. They tend to have nerve in root entrapment. So entrapment pain will not go away. And the canal stenosis, compression pain will not go away with whatever treatment. It can be reduced by neuropathic medicines, but it will not go. And also people may have weakness of the territory or area which has been involved if it is a compression. So if it is a cord compression, people can have incontinence of urine or bowel. If it is if it is exit foramen, they may have weakness of the area which is thigh or leg. So generally people call it a sciatica. If it is lumbar canal involvement or lumbar root involvement, it can be one side, it can be both sides. Whereas inflammatory back pain will settle with anti-inflammatories. It doesn't need neuropathic medicine. I hope that answers.
Yeah, thank you very much, sir. So the next question is how to differentiate between the treatment protocol of peripheral arthritis and the axial one.
Okay, right. Now, normally we give anti-inflammatories first. If it is peripheral, go for sulfasalazine or leflunomide. Again, leflunomide can be used only for boys, not for girls, because it stays in the body for 2 years. So pregnancy can be a problem. And nowadays, sulfasalazine long term also is a problem with the azoospermia, although it is described as only during the time of drug being taken. But even before, nowadays we check sperm count, so they have already low. So I'm not keen for sulfasalazine for a longer period. So peripheral arthritis, anti-inflammatories, short course steroids, sulfasalazine, leflunomide, and if need be, methotrexate. Whereas spinal arthritis, they do not benefit with methotrexate. Sulfasalazine, leflunomide may help to an extent, but biologic drugs would do far better with spinal disease. Thank you.
Right, sir. In connection to that, next question is what precautions to be taken for or before using biologics or before starting biologics?
Yes. So there is a protocol to screen patients before getting onto biologics. In fact, international centers do all these before even starting methotrexate, but we don't do that here. So hepatitis B, C, HIV screen must. MAN2 test is required in tropical countries and even in other states. And also chickenpox vaccination, influenza vaccination required. And if so, these are the common things. And if TB is excluded, hepatitis is excluded, and there is no long-term infective cause, then we are okay with biologics. But generally, biologics are being used by rheumatologists because of counseling and risk factors involved, and also legal issues. So the monitoring is done by shared care, like among physicians and rheumatologists. Patients will be educated when using them, and all the biologics, injectable ones, so it can be, it's tailor-made for patients themselves injecting, like it's insulin, it's like Cloxane, so it can be used.
Right, sir. So thank you very much, sir. These are all the questions which has been asked by our audience today. And I really thanks to you, first of all, once again, that you have taken out precious time on this weekend time. And I'm sure that everybody in the audience, on behalf of the audience also, I'm thanking you so much. And we look forward to you, sir, for the next interesting session, so that in coming month we can see or touch upon the different solution and developments in rheumatology. So really thanks to you, sir, and thank you everyone in the audience that for patience listening and giving us your time today and asking wonderful questions. So thank you very much, everyone, and be safe. Take care of yourself, and as sir has suggested, mask is must. So not only you, vaccination by you, but your co-workers as well, the hospital staff as well. So thank you very much, everyone, and be safe. Have a wonderful weekend. Good night.
Thank
Good
you.
night.
Thank you, everyone.
Thanks a lot.
Pleasure. Okay.